tube. Once again, guys, very warm welcome to the Pain Talks MSK webinar series. This is a part 2 of the webinar. Part 1 was on the upper limb, and we are going to move on to the lower limb today. So these are my disclosures. I'm a certified interventional pain sonologist. I'm a fellow of interventional pain practice. I founded Leicester Pain Education back in 2015. I'm founder of Pain Talks and Pain Flicks. I'm an editor of NYSORA Ultrasound Pain app. I work as an examiner for the FIPP and CIPS exam. And the reason, the interest of my in pain medicine education, I served as an immediate past clinical lead for ePain, which is the largest educational platform run by Faculty of Pain Medicine, Royal College of Anaesthetists, with more than 28,000 people who are subscribed on that platform. So this is a logo of Leicester Pain Education, Pain Talks, Pain Flicks, and NYSORA Pain app. So hip joint interventions is what we're going to start with. And I think this is something that is basically changed. Ultrasound has changed the way these interventions are performed, and particularly in the hip region. So hip joint anatomy, we know it's a ball and socket joint. We have the femoral head and the acetabulum with the acetabulum labrum. And the important bit to keep in mind here is when you perform the hip joint injection, you don't have to head towards this area. Basically, the hip joint capsule extends all the way over the intertrochanteric line, and I'll show that to you in the next image. But important to keep in mind is the ligaments, and the hip joint capsule adheres very, very nicely with the iliofemoral ligament, which is a very thick ligament, and 99% times when you actually are injecting this under ultrasound guidance, you will feel a pop because you are piercing this thick ligament, which is the iliofemoral ligament. So the joint capsule has anterior and posterior layers, and the capsule inserts distally in the intertrochanteric region and the posterior aspect of the neck of the femur. And this is just basically showing you that you have a capsule extending all the way at the head and neck junction, and you don't need to go all the way here. If you bring the needle and put it at the head and neck junction, you will be able to perform hip joint injection, which is in the anterior recess of the hip joint because the capsule extending into that region. Just showing you the surface anatomy, or the anatomy where you can see the neurovascular bundle. And in relation to the neurovascular bundle, you can see the femoral head and neck junction. And there are muscles that are basically related to the hip joint. You have iliopsoas muscle, you have the rectus femoris, and sartorius muscle. And these muscles are basically able to be identified using the ultrasound guidance. So when you perform the hip joint injection, and I'll show you a video in a minute, which will help you to understand things better. But majority of the people who are anesthetists would know how to perform a femoral nerve block. So you always align the ultrasound probe in the groin crease, and you look for the vein, artery, and the nerve is usually sandwiched below the fascia iliaca. And this big muscle you see is the iliopsoas muscle. You'll be able to see acetabulum and the femoral head. Once you've seen this, your aim would be to turn the probe 90 degrees and align it at the head and neck junction. So now you've turned the probe 90 degrees, and you will be able to see the femoral head and the neck. And this is your anterior recess of the hip joint. As I said, the capsule extends all the way towards the intertrochanteric line. And here you can see all the muscles, the iliopsoas muscle, sartorius muscle, and the rectus femoris muscle. And the tip here, when you actually pierce the joint capsule, given that the joint capsule adheres tightly to the iliofemoral ligament, you will feel a pop. So how would you perform this injection? And this is just showing you the position of the ultrasound probe in relation to the X-ray image. This is where you're positioning the ultrasound, and you will be bringing the needle in plane, coming from inferior to superior, looking for the needle. Tip here, every time you perform this injection, please, please, please put the color Doppler, because you will find at times there will be an artery, which is the lateral circumflex femoral artery branch, that may be in your way when you're bringing the needle. So you really want to avoid this artery. And this was one of the reasons patients used to get groin hematoma or bruising in the groin when these injections were performed under X-ray guidance, because you will not be able to see these blood vessels, and you'll go through that and you will basically cause the damage leading to the bleeding. So another important reason to use ultrasound is you can pick up all the soft tissue structures, including the effusion, and you can actually aspirate the effusion using the ultrasound guidance with real-time needling. So this is just showing you the picture. The green dotted line here is the joint capsule. This is the artery, as you could see here. Sartorius muscle is shown in purple, and the orange is the rectus femoris muscles. So these are all the structures, and this is a pattern recognition that you will have to keep in mind when we talk about the intra-articular hip joint injections. So needles that I would use for this, you will need to use a longer needle, so about 10 centimeter needle. You can use a Stimuplex needle, you can use a spinal needle. Another tip here is use a curvilinear probe unless your patient is a low BMI patient. If you use a curvilinear probe, you will get a wider field of vision. You will be able to see all these muscles along with the head and neck junction. Always try to perform this injection in plane. You can perform it out of plane, but performing it in plane will allow you to see the needle shaft along with the tip. And in the injectate for the joint, this is a large joint, so up to 10 mL of local anesthetic and steroid. Now, one tip I would give here in terms of using the local anesthetic. If you have availability of ropivacaine, that's the best local anesthetic for joints. Why? Because it's the least chondrotoxic local anesthetic. If you have lidocaine, that's the next one, which is good. If you're using bupivacaine 0.5, 0.25, or 0.75, you are causing damage to the cartilage because there's a lot of chondrotoxicity. So everything we put in the joint has a chondrotoxicity. So try and avoid using the chondrotoxic drugs like bupivacaine, and instead of that, switch to lidocaine. And majority of my injections are all lidocaine 1%. That's what I use. So use lidocaine 10 mL along with 40 milligrams of depomedrone. If you're using a PRP, platelet-rich plasma, you will need to use a higher volume here as well. About 8 to 10 mL of platelet-rich plasma is what you would inject into the joint. If there's a lot of effusion in the joint, do empty the effusion, send the sample for microscopy and culture sensitivity. Anything that comes out of the joint needs to go to the lab, because that way you can find out if there is a crystal arthropathy. It can give you a diagnosis, and it can also make you safe. So this is just showing you how the needle is basically being introduced. In plane technique coming from inferior to superior, and basically once you pierce the capsule, you can inject the local anesthetic and steroid. And this is the video manual which I just talked about, and the video manual has a video on the hip joint injection, and this is basically shot with Dr. Yahya Kamal, who is currently working in Canada. So it's a quick video showing you how to perform the scanning for the hip joint intra-articular injection.
Hi, my name is Dr. Kamal, and I'm going to show you how we perform an intra-articular hip joint injection using the anterior approach. For the purpose of the procedure, you will need the patient lying supine with the hip externally rotated, and the operator, that is myself, standing on the same side. I will use a curvilinear probe, and what I will start by doing is placing the probe in the short axis view to get the curved hyperechoic line showing the femur. I will then start to scan cephalad, and you can see there the femoral arterial pulsations in the upper screen. Start scanning cephalad until I reach the flat line, whereby you've reached the this is the anterior surface of the greater trochanter. At this stage, I shall rotate the probe, and try to get an image of the femoral head, the acetabulum, and the neck. There. It's a very good image, and I shall demonstrate there. This is the, you've got there, this is the acetabulum, this is the capsule, and this is the anterior joint recess, and this is the iliopsoas muscle. For the purpose of this procedure, we shall try to perform the procedure in the anterior synovial recess, the joint. So you need to get the image adjusted appropriately. This is an image, and I shall decrease the depth to make it clearer. So this is the femoral neck, femoral neck, femoral head, and this is the capsule, and this is the anterior synovial recess. The muscle going here is your iliopsoas, and above there is your sartorius, and then you've got your rectus femoris. It is crucially important when performing this to do a color Doppler to avoid this vessel there, which is the circumflex, which is the lateral, which is the branch, the ascending branch of the lateral circumflex femoral artery. For the purpose of this procedure, I shall use a 22 gauge 3.5-inch spinal needle, a block needle. I shall go in plane from lateral to medial, and I shall try to attempt to reach the anterior synovial recess. I will inject 4 to 8 mils of local anesthetic plus a bit of steroid, possibly 3 to 5 mils if I were using platelet-rich plasma. A tip is that occasionally with the injection, you may the hallmark of a successful block is a distension of the capsule and the cephalic direction of the fluid. Prior to that, use saline for hydrodissection. If you run into problems, if it's not spreading as it should be, you might wish to rotate the tip of the needle or adjust it by pulling it slightly out or posteriorly. At all costs, try to avoid the labrum and exit. Thank you.
So that was basically a video showing you how to perform the intra-articular hip injection. Now moving on to the next one is the greater trochanter bursa injection or the greater trochanter complex. Now there are more than 18 bursae in the greater trochanter area, and we always been just injecting one bursa, which was the subgluteus maximus bursa. So the greater trochanter bursae are basically located based on the muscles around the greater trochanter. So greater trochanter has 4 facets. You have anterior facet, posterior facet, supero-posterior facet, and the lateral facet. The gluteus minimus muscle inserts onto the anterior facet. Gluteus medius has an anterior tendon which inserts on the lateral facet, and it's a posterior tendon that inserts on the supero-posterior facet. So this is just showing you the picture of the greater trochanter. It's not just anterior and lateral facet. You have anterior, lateral, supero-posterior, and posterior facets. And there are many, many bursae that are overlying these facets and underneath the muscles. So there are 3 groups of bursae: subgluteus maximus group, subgluteus medius group, and subgluteus minimus group. So if you just inject one bursa group and patient still continues to have a problem in the hip, a lateral aspect, and the tenderness in the greater trochanter region, then you've missed the other bursae. So it's very important you assess these patients. First, do ultrasound scan. If possible, do an MRI scan that will show you if they have any primary pathology of tendinopathy of gluteus medius or gluteus minimus, because it's a tendinopathy or the problems with the muscle that gives rise to bursitis. It's very difficult to just get a bursitis per se. There's always a pathology, or patient may be walking with an abnormal gait. And this is usually a problem when patients have had a knee surgery on the opposite side, or they've had a spine surgery, because they're not basically putting the weight bearing on that side. It can lead to a contralateral greater trochanter bursitis because of the overcompensation. So this is just showing you the image of ultrasound probe put in on the greater trochanter region. And what I call this as a garage house sign. You have an anterior facet. So anterior facet is where you have gluteus minimus muscle. The lateral facet is the one which is on the other side. It's not a posterior facet, it's a lateral facet. And that's where you have a gluteus medius muscle. So below the gluteus medius, you have subgluteus medius bursa. Below the gluteus minimus, you have subgluteus minimus bursa. And then on the top of both the bursae, on the top of both the muscles, you have another bursa that is overlying. That's the subgluteus maximus bursa, because all of this is the subgluteus, is the gluteus maximus muscle, and the bursa below the gluteus maximus muscle is a subgluteus maximus bursa. You can perform this injection either in the transverse view, bringing the needle from anterior to posterior or posterior to anterior. So I take a 10 ml syringe and I divide them into 3 mLs, 3 mLs, and 4 mLs. So 3 mLs I'll inject for the subgluteus minimus, 3 mLs I'll inject it for subgluteus medius, and the 4 mLs I'll inject in the subgluteus maximus bursa. Okay, so all the bursa injections. Another tip here, when these patients come to you, not only just they have problem with the bursitis, these patients will also have a problem with their iliotibial band or tensor fascia lata. So always examine their tensor fascia lata. You'll find multiple trigger points. And if you want to get a good success with the procedure, I would advise you to do trigger points with local anesthetic of the tensor fascia lata or IT band. That will help you to get better results with regards to this intervention. So this is just showing you an image of longitudinal probe positioning with iliotibial band, subgluteus maximus bursa, and this is your gluteus medius tendon. So you can actually perform an injection in this area, and you can go below the subgluteus medius tendon, and you can perform subgluteus medius bursa injection as well. So that's the second intervention, which was a greater trochanter complex and bursa injections. Moving on to the next is the lateral femoral cutaneous nerve of thigh. Now, what are the indications? If you're an anesthetist and you do traumaless, this is a great intervention to perform for patients with dynamic hip screw surgery. If somebody's having a lateral aspect biopsy or skin grafting, you can perform this. For chronic pain, the indication is called Meralgia Paresthetica. Where does the word Meralgia Paresthetica comes from? Meros means thigh, algos means pain. So it's the patients coming to you with the thigh pain. It's an entrapment neuropathy. It could be secondary to stretching because of increased abdominal girth, secondary to obesity, pregnancy, or it could be because of diabetes, and you get entrapment neuropathies and diabetes, or if patients have had a surgery in that area, for example, bone graft. If they've done a bone grafting surgery from iliac crest and they've injured this nerve, the patients will present to you with burning, paresthesia, dysesthesia, and numbness. And patients usually keep rubbing this area, and you'll find there will be a lot of hair loss and tenderness in the lateral aspect of the thigh. So these are the commonest kind of patients with the occupation like a handyman and putting the waist belt, leading to the compression, and also pregnant women with increased abdominal girth can be predisposed to this condition. Another condition is called a low waist gene syndrome. So youngsters wearing the low waist jeans can lead to the entrapment of this nerve, leading to the Meralgia Paresthetica. Now, how do you scan this nerve? So you basically can either scan from distally and move proximally, or you can move scan proximally at the anterior-superior iliac spine, and you can move distally. So I always recommend starting distally at the position 3. Why in the position 3? Because this particular area is called as triple FT, fat-filled flat tunnel. So you ask the patient to raise the leg, and you can feel this dip between these two muscles, sartorius and tensor fascia lata. And then once you feel this groove, put the ultrasound probe on the top. So always feel before you put the probe. So always palpate before you scan. Once you've scanned this groove and once you've seen the nerve, you can scan the nerve proximally, and then you can block the nerve proximally, as usually the problem is in the proximal part of the anatomical location of the nerve. Just showing you at 3 locations: tensor fascia lata, sartorius muscle, and the nerve on the top of the tensor fascia lata. And this is a location 3 in the fat-filled flat tunnel. And this is midway between the top and the bottom is at position 2. Now, how would you perform this nerve block? You can do an in-plane technique, bring the needle in plane from lateral to medial, or you can go medial to lateral, and you can inject 3 to 4 cc's of local anesthetic and steroid. If I'm using dextrose hydrodissection, you can use 5% or 10% dextrose, and you can hydrodissect it with about 5 to 10 mLs of dextrose and free off the nerve. As I said, this is an entrapment neuropathy, and you want to free off the nerves. You can also perform pulse radiofrequency treatment of this nerve, and the settings will be 10 minutes, 5 minutes, 2 cycles, 42 volts, 42 degrees. So that's how I would do it. So this is volume 5 mLs. If you're doing hydrodissection, 10 mLs of 5% dextrose. Pulsed RF, you can use 5 centimeter needle, and you can use 42-degree settings for 5 minutes, 2 cycles. You can also do what we call it as neuromodulation which is in the form of the peripheral nerve stimulators. You can put a nerve stimulator next to the nerve under ultrasound guidance. And this is a very good case report telling about peripheral nerve stimulation as a new treatment for Meralgia Paresthetica. If you're interested, then you can access this. So moving on to the knee joint interventions, so hip joint interventions. If you have any questions with regards to the hip, please put it in the chat box and I'll take it at the end. So knee joint interventions, so knee injections. Starting with knee injections, in the longitudinal view, you have quadriceps tendon. As it says quadriceps, even though there are three layers, the vastus medialis and vastus lateralis, they come together and form the middle layer. So you have top layer, middle layer, and bottom layer. And this is very useful when you want to look for the pathologies of the quadriceps tendon. Then we have a patella. On the top of patella, you have a suprapatellar fat pad. You have femur. On the top of the femur, you have prefemoral fat pad. And between these two fat pads, you see the asterisk. This is the suprapatellar recess, which is the recess of the knee joint. There are 8 approaches to the knee joint injection. The one that's commonly performed is a lateral approach. So this is just showing you the joint effusion. And if patients have joint effusion, you will not miss it. You will be able to pick up the joint effusion very easily with the ultrasound. Once you have scanned the knee in the longitudinal, then you will move the probe transverse. And you'll basically be able to see this. This is the transverse position of the probe, and the needle is going from lateral to medial in plane technique. And you can then aspirate the joint. You can inject the joint with PRP. You can inject a hyaluronic acid. You can also inject local anesthetic and steroids. So this is the, and you can also inject phenol as well. So people have injected phenol for patients for palliative care, someone who has got a severe knee pain. So why to use ultrasound? This is a great article from Mark Hurdle, who's one of our faculty members, and he wrote this paper back in 2012, so nearly 12 years ago, 11 years ago, saying why to use ultrasounds. If you have a patient with a high BMI, imagine orthopedic surgeon injecting this blindly, which I mean is anatomical landmark or surface anatomy. How are you going to be sure if your needle tip in the intra-articular region? So this is where you want to use these kind of patients. And even also in the patients with normal BMI, it's very important to know where your needle tip is and where are you injecting the medication, especially if you're using hyaluronic acid or platelet-rich plasma, because it's an expensive treatment and you want to get the injected in the right area. So conventional radiofrequency, and this is something that's very close to my heart. I've performed about 1,000 radiofrequencies, 1,000 plus, performed 3,000 plus genicular nerve diagnostic blocks. So conventional RF is something that is basically well known, and it's coming up quite well known in the field of interventional pain management for knee pain. Now, when you talk about what's new with regards to the joint innervation, this is a great paper from John Tran, who's actually currently in an audience. John Tran is basically an anatomist from University of Toronto, UFT, and he is written this phenomenal paper with Philip Peng and Mike Gofield and Ann Arger, telling about the new targets for knee joint denervation. So new joint, we knew in the past that the nerve to vastus medialis and nerve to vastus lateralis, and we always put the needles, but those nerves are not the sort of actual nerve to vastus medialis. They were intermediate branches dividing into medial and lateral. What I mean by that will be explained here. So this was the old target. This is where you would get your nerve to sort of medial branch of nerve to vastus medialis. Actual nerve to vastus medialis or superomedial geniculate nerves are located in this area. And this is the adductor tubercle. So this is a new target. That's the old target. So if you want to catch the nerves, the actual nerves, which are the superomedial geniculate nerves, this is where you need to locate your needle in addition to the old target. Old target is important, but this is a new target. Then the other thing they've described as well, similar to the medial part of the joint, you have a lateral part of the joint where if you want to target the true or the actual superolateral geniculate nerves, you need to go on the posterior aspect to catch them, because the old target will only give you the lateral branch of the intermediate genicular nerves. So this is the old target, that's the new target. And I'll tell you, the inferomedial genicular nerve target remains the same. The important bit to keep in mind, you need to position your needle below the medial collateral ligament. So this is the old target, that's the new target. This is the old target on the lateral side, and that's the new target. And this is the old target, which still remains the same for inferomedial geniculate nerve. Now, how would you perform the nerve block? So either you could put a bolster or a pillow under the knee. If patient can turn the leg in the figure of 4, it's always useful, because then you can put the ultrasound exactly perpendicular, looking for the fascial covering. This is the vastus medialis muscle. You have the shaft and the condyle junction, and this is the area where these nerves are located. You can turn the probe, and you can also look at the shaft and condyle junction transversely, and you can also bring the needle in plane. So there are 2 ways to do this. Now, always put a color Doppler. Why? It's important to put the color Doppler because these nerves are all accompanied by the artery. About 80% of times, you will find the artery accompanying the nerve, and you will be able to put the needle next to the artery, which will help you to catch the nerve. If you don't see the artery, the advice would be go at the junction of the shaft and the condyle. So where the bone starts to kind of slope up, this is where you would go. So this is just showing you junction, condyle, shaft, and this is the target. You can then turn the probe around looking for that same junction, and you can bring the needle in plane anterior to posterior. And this is just another figure image showing you the artery that's basically located at the junction of the shaft and the condyle. So a great way to do this. Now, how do I do it? So I'm just going to tell you my technique, and I've improvised my technique over a period of time. So this basically is the patient who has only medial knee pain. He doesn't have a lateral knee pain. So I only perform superomedial and inferomedial genicular nerve block as a diagnostic block, and followed by that, then I perform the radiofrequency. So I'm just going to show you how to perform radiofrequency. You can see the pillow under the knee. What I would do, I would put a drape, and then I'll clean the area. Once the cleaning is done, then I have my setup. This is a setup. I have an X-ray machine. I have an ultrasound. Now you can perform the whole procedure without needing the X-rays. The entire reason to use X-ray is for medical legal purpose, because if you perform a radiofrequency treatment, and if you're burning somebody's nerve, you need to have a proof that you've burned them in the right location. And in my hospital, we didn't have a facility to save the ultrasound images. So we always use X-rays as a way to save the image on PACS. And that's why we're using the X-ray. Now you can see I'm cleaning the area with the Clo Prep. Then I've draped the area. So this is like you're performing a mini operation, like an arthroscopy. And always keep in mind, once there is an infection in the joint, there is an infection in the joint. So it's very important that you take utmost care of the antisepsis. And this is what I would do. So you've draped it. Once I've draped it, before I put a needle, I will again clean this. And this is what the orthopedic surgeons would do. They will chain the gloves. They will clean it one more time before they make the incision. So this is what I would do in my practice as well. Once you've done that, this is what the mixture is, a local anesthetic. So I never gave sedation. I may say never, but very rarely I have given midazolam. Mostly the whole procedure gets performed with judicious use of local anesthetic, okay, 1% lidocaine. I've ditched steroids. I do not use steroids in any of the radiofrequency treatments now, because amongst those 1,000 plus radiofrequency treatments, I've had 1 infection, okay? And that was a patient where I had used steroids, but there were multiple factors. The patient was on the chemotherapy. He did not tell me that he's currently receiving chemotherapy in another hospital. And he basically underwent the procedure and had the infection and needed some antibiotics. So I'm not using steroids anymore and surprisingly, you will find it's not the issue of neuritis with this particular procedure. If you put plenty of local anesthetic after the procedure, after the RF, you will find the patients don't develop neuritis. So this is the setup. You have the ultrasound probe covered with the ultrasound probe cover. And this is now ready to go. We have the X-ray, we have the ultrasound, and we have the radiofrequency machine parked on the same side. And what I would do to start with is scan the area and locate the junction of the shaft and the condyle. So this is the superomedial genicular nerve I'm actually targeting. I would say it's a genicular group of nerve. That's how I would consent them. Genicular nerve group block, because it's not just one nerve, it's a group of nerves. So this is the inferomedial genicular nerve group block, or nerve group radiofrequency. You can see the arterial pulsation. This is a tibial condyle and the tibial shaft. And now, once you have actually located the junction of the shaft and the condyle, I'll put a marker pen on the skin, and then I'll turn the probe to 90 degrees, and then I'll start to use a local anesthetic. And then I'll position my needle. Same thing I'm doing for superomedial. So once you have positioned the needles, then only I'll do the X-rays. I never do the whole procedure with the X-ray. The X-rays are done at the end. So this is the AP view, and as you can see, the needles are positioned at the junction of the condyle and the shaft, and this is where I found the artery pulsating, so I've decided to go next to the artery. Same thing for the inferomedial junction of the condyle of the tibia and the shaft. Once you've done that, do a lateral X-ray, and this will tell you how deep you are. As I said, you don't need to use X-rays at all for this procedure, but this is for the medical legal purpose. It's telling me that my needle is located between the anterior and middle third of the shaft condyle junction. So this is the whole of the shaft, and this is where you would like to keep your needle. Same thing with the tibial condyle shaft junction. The needle is actually in between the thirds of anterior and middle third of the shaft condyle junction. So just showing you, this is the new target. This is the adductor tubercle, and you can use ultrasound to locate the adductor tubercle, and I park the needle just on the top of the adductor tubercle. And this is what I'm doing. This is a bipolar. You can put two needles and can create a bipolar lesion. This is the sort of, old target that still stays the same for inferomedial genicular nerve. So once again, recapping, this is the old target. That's the new target, which is the adductor tubercle. This is the old target. The new target will be much posterior. And inferomedial genicular nerve, the target stays the same. Okay. Now, when you talk about the needles, there's a plenty of options. If you're doing radiofrequency, you can perform palisade technique or stack lesioning. So you can pull the needle out a few millimeters and you can stack lesion on the top of each other. You can use a cooled RF. You can use bipolar RF. You can use trident needle, which is also available, which basically opens up and can give you a very good big spherical lesion. So there are various, there is a venom needle also available, which is basically called a sidekick cannula. So you can actually create like a bipolar lesion and a big lesion. So there are many, many approaches to perform radiofrequency. And if you guys are located in Dubai or fancy a trip to Dubai in October, then we will be sharing all of this in that international course in Dubai on de-innervation. Plenty of details will be given, including cryotherapy, and same thing will be taking place in Leicester in November, on 7th and 8th of November. So please join us. Now, what the course is going to do, and these are the questions I usually get asked: how to assess the patient, what is a positive or negative diagnostic block, what is the appropriate selection of patient, which nerves to target, what happens if they have spinal cord stimulator, if they have pacemaker or ICD, can you do a radiofrequency in those patients, and how to do it, and how many lesions to perform, what is a cryo setting, what is a radiofrequency setting, what type of needle you use, what probes you use, how to perform in plane, out of plane. All of that will be discussed on that course in Leicester and also in Dubai. So that's the knee joint radiofrequency. Moving on to the last part of the lower limb MSK interventions is the ankle joint. This is called the talocrural joint or tibio-talar joint. It's a joint between the talus, talar dome, and the lower aspect of the tibia. So how do we perform this? Is basically you use the ultrasound and put it on the longitudinal view, looking for the talar dome and the undersurface of the tibia, and basically bringing the needle. Either you can do it out of plane or you can bring it in plane, and I perform in plane technique where you can see the needle tip going into the joint, and when you inject, the local anesthetic and steroid will float into the joint. You can also perform transverse view. These are the settings. You can use a 25 gauge or 27 gauge. This is a small joint. 3 to 4 mLs of local anesthetic and steroid is enough. You can use linear frequency, like high frequency linear ultrasound probe. You might need to do plenty of gel, and we call it a gel standoff technique if the patient is very low BMI. So you might have to put a lot of probe to see the joint, a lot of gel to see the joint. Plantar fascia, this is another injection technique that can be very elegantly performed using the ultrasound guidance. Now, things that I would give the tips here, I perform plantar fascia injections. Before I perform plantar fascia injections, I do a tibial nerve block. So use a 1% lidocaine, 4 mLs of 1% lidocaine, do a tibial nerve block. Once you've done that, the sole of the foot gets nice and numb, and then you can perform this injection without causing too much of discomfort to the patient. So the procedure can be performed in a longitudinal view or in the transverse view. I use a transverse view. You find the maximum tenderness on the plantar fascia, put a skin marker, put your ultrasound probe, and then you look for the plantar fascia. So this is just the picture, the ultrasound imaging. You have calcaneus, and this is the plantar fascia. If you're performing the PRP, you will go into the substance of the fascia. We will put dry needling plenty of times, and then after that you can put in PRP. If you're performing the injection with local anesthetic and steroid, you have an option either to go below the fascia or above the fascia. People recommend going above the fascia because below the fascia you have a fat pad, and sometimes you might end up injecting in the fat pad. And the reason the steroid injections work better for the plantar fasciitis because it reduces the thickness of the fascia. It thins out the fascia, which indirectly reduces the pain. So this is the preferred approach. Patient position, they may be laying on the tummy, so you can put the patient prone, or you can put the patient on the side. You can use the linear ultrasound probe. You can do in-plane technique, medial to lateral or lateral to medial. And the Baxter's nerves, these are the nerves from the lateral branch of the lateral plantar nerve, which is a branch of tibial nerve. So Baxter's nerves, they lie deep to the fascia. Avoid injection into the fat pad because that can lead to the atrophy. Consider tibial nerve block before injecting the fascia. So that's all about the lower limb MSK. We went through the hip, followed by knee, followed by the ankle and the plantar fascia. I'm going to stop the screen share and I'm ready to take questions.
Excellent, Sadiq. I mean, you almost covered such a big topic in a short span of time, and good images and videos by especially Yahya and others. So let me see what questions do we have here. Yeah, the first question was by Farshad, if can the videos be available? So I wrote him, yeah, it will be available on your Pain Talks video, Pain Talks YouTube channel. You can share more about that.
Sure. So Pain Talk YouTube channel is, when you look at your Zoom link, there is a kind of a link to click on, and you will be able to direct yourself on the YouTube channel of Pain Talk. And all the previous videos and this video will be available on that as well. Okay.
Khalil has asked, would you like to comment about PENG block?
Okay, so PENG block, basically PENG stands for pericapsular nerve group block. Okay, described by Dr. Peng from Toronto, and it's essentially a block under the iliopsoas muscle. Okay, so you have iliopsoas tendon, and below the iliopsoas tendon, once you pierce the tendon, you inject 20 ml of local anesthetic, which will essentially block all the nerves, because the nerves, they actually go below the tendon in the interfascial plane and then enter into the joint capsule. So if you inject 20 ml of local, you will block femoral articular branches, you will block obturator articular branches, and you also block the accessory obturator nerve branches going to the hip joint. And that's what people are now doing to provide the pain relief with minimal muscle weakness, because you are actually putting a local anesthetic way too distal, away from the major nerve trunk, reducing the muscle, reducing the chance of getting muscle weakness, but providing the long-acting pain relief for patients with hip fractures.
Excellent. The next question we have is by S. Chandran. What concentration of ropivacaine would you recommend for joint injection?
So basically 0.37, 0.5 is good enough concentration. 0.25 is also okay. So Dilute version is what you need, because if you put a much stronger version, it is more chondrotoxic. As I said, if you inject 0.5 bupivacaine, percent bupivacaine, it's more chondrotoxic as compared to 0.25. So try and minimize the toxicity by using a weaker local anesthetic.
I agree. I mean, we are using 0.06 to 5% for epidural labor analgesia, and it's working, right? So trigger points, I generally inject 0.1 to 5%. It doesn't hurt a lot. It works well. You can use larger volumes and longer duration of relief. So, I mean, up to 0.125 is what I have used, and that should be good enough. Next is a thank by John Tran. John, welcome. Nice to have you here. And then we have by John Wilton. How often do you see and treat tarsal tunnel syndrome? What is the preferred approach for hip denervation? So these are two questions.
Okay, two questions. So question, John runs a very successful Facebook group, by the way, Amit, known as Ultrasound and POCUS. Okay.
Oh.
It's got more than 15,000 people on that group.
Oh.
So thanks for joining, John. John works in US, actually, Mount Shasta. That's where he used to work. Amazing place, a dog lover, and has a great kind of, Facebook page. So in regards to the tarsal tunnel syndrome, I find this like a Pandora's box. Basically, tarsal tunnel syndrome, various differential diagnoses. When you come across the patient with the heel pain or burning pain in the sole of the feet, it should point you towards either a tarsal tunnel syndrome or Baxter's nerve entrapment or plantar fasciitis, because even the plantar fasciitis patients can have burning pain, because a nociceptive pain can present as a neuropathic pain. So I probably would say, it's a very common condition, but you have to look for it. So always when you come across patients with burning pain in the feet, you really need to find out. And these are the patients which sometimes get completely overlooked. If they have had a back surgery, everybody thinks that the pain is coming from the nerve entrapment high up in the spine. They might have failed back surgery syndrome, and it's a post-laminectomy pain syndrome. Always examine these patients, try to do Tinel sign, try to feel for the tarsal tunnel, and you will be able to do. And usually this is a unilateral condition. Patients with failed back surgery syndrome will have bilateral burning pain in the feet. Unilateral usually is tarsal tunnel. So easy to do a block like carpal tunnel. You ask the patient to move the toe. You look for the flexor hallucis longus, FHL tendon, and the nerve is sitting on the top. And on the top of the nerve is your flexor retinaculum. You go below the flexor retinaculum, you don't even need to go towards the nerve. You inject 5 mL of local anesthetic and steroid, that's a tarsal tunnel injection. So that's the first question. Second one is, what is your preferred approach to the hip joint denervation? So preferred approach, I would basically block all 3 nerves, obturator, accessory obturator, and femoral. I use a cuff technique, combined ultrasound and fluoroscopy technique. I'll use the ultrasound to guide the needle for femoral. So I'll go just lateral to the iliopsoas tendon and do the legioning there. Then I'll go on the other side of the iliopsoas tendon, and that will block the accessory obturator nerve. And then for the obturator nerve, I'll do as you would do for the hip joint and move the probe medially, looking for the inferior part of the acetabulum, or what we call incisura acetabulum, and then do the X-ray to look for the what we call teardrop sign. And you basically park the needle lateral to the teardrop, because if you put the needle medial to the teardrop, you'll get muscle weakness. So you really want to do this carefully. So that's what I would do. I would block all the nerves, use either a cooled RF needle or use 18 gauge needle and perform palisade technique, basically stack lesions. So do 3 lesions each nerve. That's my approach.
Yes, excellent. We have next question by Dr. Pradeep Kumar Ravi, and he's asking why you prefer 1% lidocaine. Can use 2% lidocaine safely for local steroid injection?
2% lidocaine stinks. That's number one. And what I am doing is to minimize the medication errors. I'm just using 1% lidocaine for the skin, and the same 1% lidocaine goes into the nerve block. So less drugs, less worries of mixing drugs, and 1% stings less. 2%, as I said, is more chondrotoxic if you use 2%. As compared to that, you can use 1%, or you can dilute it with saline and make it 0.5%. but 1% is because it's easier. It's available as 1%. You draw it up and you inject in the joint.
Well, yeah, you need analgesia and not anesthesia. So 1%, I agree.
Sure.
We have some comments. I'm not sure what that means, anterior sciatic. So I don't think that's a question. There are some comments again about instead of radiofrequency, you can use neurolysis.
Yes, you can use, and that's the whole lecture from Tony NG from Australia. So Tony is actually originally from Hong Kong, but he's now working as a consultant in Australia. And he's actually done a phenomenal lecture on the knee and hip neurolysis or using alcohol and phenol. So that's available on
It was an excellent lecture, yeah.
channel. Excellent lecture. So he's basically done that talk, so it's easy to access that. So thanks,
So
Erwin.
we have one. Are you reading the questions?
Yes. Go on. Sorry, I'm reading.
So we have one question by Iyad Fadel. Is it necessary to block tibial nerve and sural nerve for plantar fascia injections?
I don't block the sural nerve, to be honest. I do block tibial nerve. It's not necessary, but if you do it, the patients will be very comfortable. And Amit, we have done this together.
Yeah. I mean,
especially in an elderly patient, given that that particular part of the sole is very sensitive, the skin is thick. If you put the needle through that, it's very painful. And if you want the patient to have a comfortable experience of your pain intervention, and if you want the patient to come back, it's better to do a block.
Yes, it should be as with the least amount of discomfort as possible.
And it does make,
because they would come back. They would come back. You don't want your any procedure to be more painful than the pain, primary pain, index pain itself.
So that's why it's always better to do a nerve block before you do the plantar fascia.
And then again, we have a comment: caps lateral block for knee. I'm not sure what that means.
It's probably asking about the lateral block for knee. So lateral block for knee is if you're asking about the inferolateral genicular nerve, it is possible to do inferolateral genicular nerve, and this will be one of the demos on the course in Leicester as well as in the Dubai. It's a specialized technique, especially if you're new to the innovation world. I won't recommend you do this because the nerve is very close to the common peroneal nerve, and you can give a foot drop to the patient. So it's very important to scan for the widest part of the fibula, and the nerve is usually at the junction of the tibia and fibula, widest part of the fibula, and you can do the block in that area.
Then we have the last question. Is it necessary also to check Achilles tendon also?
Obviously, tendo-Achilles tendon is another one which can be one of the causes of the ankle pain, especially in the posterior area. And you can look for tendinopathy or tendinitis. And people do platelet-rich plasma injection. Never inject local anesthetic and steroid in the tendon because you can rupture the tendon. If you want to inject the local anesthetic and steroid, you can do a retrocalcaneal bursa injection because that's one of the bursitis that can be present in the patients with tendo-Achilles tendinopathy. So this is where you would do it.
So that's the last chat message we have about the questions. I have one question to you, Sadiq. I mean, you mentioned about like at least 5 to 6 type of needles for reinnervation of the knee joint, right? You have monopolar, you have, then you go for bipolar, then you have Cooley, then now you have cryo. If I ask, I mean, and with any setup, right, you cannot have all the needles possible.
No.
so if I give you a choice, choose one of them, which needle would you choose? I mean, very practical question. With all your experience.
I would say bigger is better. So I would go with 16 gauge if it's available in your setup. Okay, 16 gauge needle is a very big needle, by the way. But bigger is better because you will need less lesioning because you're performing a big lesion with the 16 gauge or 18 gauge. If you have 18 gauge, amazing, right? The other thing is, if you ask me the ideal way of performing knee RF, I would do bipolar, 2 needles, 18 gauge next to each other, okay? And this is what I would do in patients with cardiac pacemakers, ICD, spinal cord stimulators, because when you do bipolar, you have electric current between the two,
and then you have a larger lesion.
And you won't need to do
I totally agree.
anything. And you get a bigger lesioning and you pull the needles at the same time and you keep creating the lesions, and you get not only the stacked lesion, you get big lesion of 1 centimeter, because if you're putting 18 gauge needle, you're getting half centimeter. So essentially you get 1.5 centimeters of big lesioning for the nerves. So,
and a very big warning for all the people who do, I mean, who are new to this, that if you are doing inferomedial nerve ablation,
Yes.
You have to make sure that your needle is deep enough under the skin. Otherwise, the skin burns and tissue avulsion is
Ulcer.
possible
Can be right.
and also documented very well.
That's true. Okay, so
I
that's it.
think we
Looks
have
like
done,
they're a grand
Sadiq. That's an excellent, excellent presentation and good questions and very well answered.
Thank you so much. Thanks a lot, Amit. Thank you, everyone. Great to have you all. I think we've had, our surprise Sunday evening, and we had about 75 people at one point.
Amazing attendance.
Thank you so much, Amit, for moderating the event and,
Pleasure.
Okay, have a great evening, everyone. We will be basically putting this talk on the YouTube channel, and we will send you the link as well. Take care. Bye-bye now. Bye.
Bye-bye.